treatments that we use for IBS. Much less for UC, for ulcerative colitis, but a lot for irritable bowel syndrome. SIBO, irritable bowel syndrome, that's basically our last and treatment.
And what about the irritable bowel syndrome? Is that common in Vienna?
1 out of 5 women.
Oh, 1 out of 5 women. Okay.
1 out of 10 men.
Oh.
And we have developed a procedure called bioflush. We presented this bioflush, which is endoscopy where you remove biofilms. You probably have seen our paper in gastroenterology. I think it was in 2022, maybe 22. First author is Max Baumgartner, and presented that IBS and also IBD are strongly linked to intestinal biofilms, which you can recognize endoscopically. Without microscopy, you see these biofilms. Typically, doctors were thinking this is a bad prep, but instead it's a biofilm. And for removing them, we have a solution. It's a specific solution using sodium hypochlorite, which is basically what women use when they want to get blonde hair. They put it into their hair. So we use this in the small and large intestine and remove biofilms. And this is very effective, I have to say. We have a 70% response rate, which is lasting, over a year and longer. So this is something that causes a lot of work to us. Yeah. Because a lot of IBS patients, they all want to get these biofilms removed. Patients are traveling from all over somehow patients know this very fast. They're very organized. They're coming from Canada, from New Zealand, from Australia, from Europe, all over Europe. I haven't had an Indian patient, I have to say.
I think there are a lot of people, they tried everything on earth and they say it's not cured. So maybe they can come for your it's called bioflash. What, say it again?
Yeah, bioflush. Yeah. We remove, so you basically flush the biofilm with this solution endoscopically. You remove the biofilm, and this is basically solving this in at least 70%. It's really a technical issue. If the biofilm goes very far into the small intestine, and that scoping the small intestine is not so easy, then we are not as good. But if you reach the upper limit of the biofilm, let's say 25 centimeters over the ileocecal valve, and you can remove the complete biofilm, patients are very happy, long periods of time.
What type of solution you use to flush?
It's called, we have written an gastroenterology review where we described it. You just look up my name in gastro, and this was, I think, published last year or this year. It's called Actimaris. It's a Swiss company, and it's very safe. No side effects.
Okay, I will go through this article because many people are very much interested, to cure this problem, because especially the travelers, whenever they go for especially international trip, they are more worried and they get more IBS. Especially in the long travel in the flight, they really having a lot of nightmares to travel. So I think this bioflash I'll go through. I don't know whether anybody in India do this. Let me check with our gastroenterologist.
Yeah.
How do you read it?
So 4 more minutes, Sanjay. I think we'll start. Everybody's ready? Back in Ramnath?
Yes, sir. Yes, sir. We are ready to go live. And link is.
And what about other centers also ready? Make them alert, and then we'll start.
Subha? Yes, sir.
Professor Chris, Christoph, can you stop sharing your slides because I'll have to show some slides.
Okay.
Yes, fine. Thank you.
Subha, link is live, no, for audience?
Yes, sir.
Yeah, perfect.
Subha, are you ready with my slides?
Yes, sir. Your slide is also ready.
Oh, Shobha, let us know when sir can start. We'll accordingly will initiate.
Sir, we can start exactly at 9 Indian time.
Will you give some indication
Yeah,
time?
you count 5, 4,
Count,
3, 2,
yes.
1 like that. Then I'll start. Okay.
Okay, sir.
Sure,
Sure.
so just allow us 2 minutes more. It's 20:58. So sharp at 2100, we'll start, sir.
No, you give
Sure.
me a clue. You say 5,
Sure, sure,
4,
sure.
3. Yeah.
I'll do it, sir. I'll do it.
You count the 5, then I'll
Count.
start. Okay.
Sure, sure, sir.
Because your timing and my timing may be 20 seconds different also.
Yes.
Sir, start.
Okay. Good evening, dear brothers and sisters. I am very happy to welcome all of you for a very, very interesting webinar on iron deficiency anemia, what is new. We have a very good speaker, internationally known stalwart. Can I have my slides, Subha? The speaker is Professor Christoph Kasch. And in next slide. Next slide, yeah. This webinar is a scientific web-based program designed specifically for healthcare providers. Iron deficiency anemia is very common, and conditions like IBD cause iron deficiency, leading to fatigue and reduced quality of life. You know, when some people have anemia, they have got a lot of problems. They always feel weak, fatigue, and cognitive functions may also be affected. This theme, open your eye to new frontiers in iron deficiency management, broadening understanding and updating clinical practice. The primary focus is on iron replacement therapy with oral ferric maltol across inflammatory conditions. Next slide. So today, to talk to us about this interesting topic, most interesting topic, also it's a neglected topic. That's why we have taken, because day in and day out, everybody is facing some cases of anemia. The anemia may be due to iron deficiency or maybe due to anything else. People without anemia also may have iron deficiency. That's an important point, they forget. So people who has no anemia may also have iron deficiency. So this topic is going to be an eye opener. And to talk to us, Professor Christoph Gesche is a MD, AGAF Medical University of Vienna, Lohofer Life Center for Gastroenterology, Iron Deficiency, Vienna, Austria. His membership in Professional Society is the International Organization of Inflammatory Bowel Disease, International Society of Gastrointestinal Hereditary Tumors, European Society of Gastrointestinal Endoscopy, American Gastroenterological Association, American Society of Gastrointestinal Endoscopy, Austrian Society of Gastroenterology and Hepatology, and he has contributed a lot of things in research. He is a chairman working group on phenotypic classification of Crohn's disease. It's called Vienna classification. The research focus is on IBD immunogenetics, ILIOR, NDO2, inflammatory related colorectal cancer, chemo prevention, and secondary thrombocytitis in iron deficiency. Academic output, he is amazingly editor of 6 books, 27 book chapters, and more than 300 national and international lectures. Next slide. Now, as I said, this program is live streamed in 5 different places across the country. One is the venue is Vijayawada or Vizag. Every center have got lot of people, delegates are attending. Every center has got a moderator. In the venue in the Vizag, the moderator is Dr. Ramani. She is a MBBS, DGO, MS General Surgery, is the gynecologist, obstetrician and laparoscopic surgeon, practicing since 1993 with 31 years of experience. He is also a member of ASI, Foxy and IMA. She received Best Doctor Award in 2014, Community Service Award in 2014, and IMA National Award 2013. Next slide. I am pleased to introduce the moderator from Nagpur. Is Dr. Sankar B. Kobargade. He is MD Medicine, FIMS, FGSC, MBA, MPhil, Buddhist Philosophy. He is a diabetologist and TB specialist. Ex-member and co-convener, Ethical Committee, Maharashtra Medical Council, Mumbai. President, Association of Physicians of India, Vidarbha chapter, which was inaugurated by me about 20 years back, and winner of All India second best branch prize. Next slide. And our third venue is the Guwahati. Dr. Dipjyoti Das is an MD anesthesiology in critical care, assistant professor, critical care, senior resident, Guwahati Medical College and Hospital 2023-25, deputy consultant, critical care, Health City Hospital 2018-2023, anesthesiologist, Pandu, FRU 2018. Next slide. The next venue is Hyderabad, Dr. Kiran Macha. He is a general physician with 10 years of experience, including 8 years at Apollo Hospital, worked across the UK, US, and Canadian healthcare system, former research director at UNF University, USA, with multiple degree publications and books. And the next venue is Cuttack. Dr. Purnachandra Rath is MD General Medicine, Senior Consultant Physician, Managing Director of Euronephro Center of Excellence, a former Senior Medicine Specialist, Government of Odisha, Member Indian Medical Association, Association of Physicians of India, Research Society, RSDA, and many my good friends and physicians are there. I could see them in the video. So today the topic is very interesting. Iron deficiency anemia is not a solitary disease. It always accompanies many chronic disease. To talk to us more about this, now I request our Professor Christoph Gash to deliver his talk. Over to you, sir. Please welcome him with a round of applause wherever you are, please. Over to you, sir.
Yeah, thank you very much, Nathan. We are pleased that I can talk from Austria to India, just over a little bit of 3.5 hours time difference. And I can talk about my most favorite topic, iron deficiency in gastroenterology. So let me start here by remarking that iron is an essential component for every cell in the body. Of course, cells that are high in metabolic activity, such as the heart or the brain, need a lot of iron. and are very much depending, but it's basically every cell in the body that needs iron. Who is mostly affected? Of course, women of child bearing age. So menstruating women are the ones who are mostly iron deficient, young women, middle-aged women, pregnant women, children. We have also a lot of athletes, specifically marathon endurance athletes that are affected by iron deficiency. And of course, I think vegetarians, and this is an Indian issue, and elderly are also at risk. So just to explain my situation, I'm professor at the Medical University, and we are running also a private institute, which is called LOHA for Life, which is specialized in gastroenterology and iron deficiency. And I would like you to take part of a little journey over 30 years of iron deficiency in gastroenterology. It was in the early 90s of the 20th century that I started to get interested in iron deficiency, and it started actually with IBD. And then we got a lot into research. We do a lot of mouse models, cell culture. I will get you a little bit into basics of iron research. And then I will talk about clinical trials with ferric maltol, specifically in IBD-associated anemia. And I think you're going to be very interested also in the safety profile of this ferric compound. So, inflammatory bowel disease associated anemia. This is, and I would like to emphasize, the most common extraintestinal complication of disease. You can see on the endoscopic pictures that there is ulcerations of the intestinal surface, both in Crohn's disease and in ulcerative colitis. And this ulceration is basically the reason why iron is lost through chronic intestinal bleeding. In ulcerative colitis, as the bleeding typically is very distal and visible, patients are coming fast, and iron deficiency is not as common and frequent as in Crohn's disease, where the bleeding is more proximal and not visible to the patients, and iron deficiency typically is overlooked a lot if we don't take regular tests. Besides iron deficiency, there are other causes for anemia in IBD, which is, of course, inflammation, and I will get into this a little later. And there is nutritional deficiencies, which are getting rare, but also medications such as azathioprine or methotrexate that can cause anemia. Inflammation causes disease activity, and so disease activity is also linked to anemia. And we already heard that anemia is one of the drivers of lower quality of life, and it's a recurrent chronic issue, so we should really do something against it besides taking care of IBD itself. So I said it's a 30 years journey, and this is a very old paper. Actually, I think this is the first paper I published on the topic. See, this is September 1994. Anemia in Crohn's disease, importance of inadequate erythropoietin production and iron deficiency. So this was basically a study where and you couldn't publish a study like this in the year 2025 anymore, with 16 anemic patients and 33 non-anemic patients. And we compared parameters. We compared the disease activity score. We compared inflammatory parameters like C-reactive protein or alpha-1 acid glycoprotein. And we compared parameters of iron metabolism and erythropoietin. And if you look at the significance level, is that, for example, the C-reactive protein was not significantly different between the ones with anemia and the ones without anemia, while, for example, the ferritin, which is basically reflecting the iron stores, is significantly lower in the patients with anemia compared to without anemia. Erythropoietin was increased, but if the increase should be always adequate to the amount of anemia, according to the standards at that time, it was considered inadequate because of inflammation. So if we look into the IBD population and iron deficiency, during various studies, the prevalence is high between 36 and 90%. I already said the most important reason is chronic blood loss. However, there's also reduced intake and impaired uptake. And there's commonly more iron lost during bleeding than iron is replaced by food or drug. And there is another issue, and I will come into that ferrous iron is commonly not tolerated in the IBD population. So this is another paper of the 90s. Look at this, 97. This paper basically was the consequence of the previous paper. We said, there is a lot of iron deficiency and there might be EPO deficiency. So we did a randomized trial, randomizing patients to placebo, and this is an IV iron product, iron sucrose, and erythropoietin and iron sucrose. And if those who are my age might remember, erythropoietin at that time was a very new drug. It just was used for dialysis patients, and we started using it also for anemia of inflammation. And what you can see on this slide is actually interesting, that the iron replacement therapy by itself was doing an increase over 2 grams per deciliter hemoglobin during a period of 8 weeks, together with placebo, in 75% of patients. And if you add erythropoietin, the increase was faster and more pronounced, up to 95% of patients. So with this trial, actually, we showed that almost every patient can be normalized in hemoglobin using IV iron and EPO. And so following that, there were a lot of reviews that we needed to write, and book chapters and guidelines for the management and systematic reviews. So this is something that came past this very important paper. Further down the road, we also developed further IV drugs like ferric carboxymaltose. And we developed a very simple dosing regimen where patients with a mild anemia and lower body weight would receive 1 gram of iron intravenously, and those with a higher body weight, 1.5. And if the anemia is more significant, it's 1.5 and 2 grams. So this was an improvement for clinical practice, not to calculate the iron deficit anymore. But let's switch to the oral drugs. So at that time, there was only ferrous iron, Fe2+. And this Fe2+ is poorly absorbed in the duodenum. And if it's not absorbed in the duodenum, everything is passing through the gastrointestinal tract until it appears in the poop. This is why the poop is dark or black when patients take iron tablets. If you look at this here, this is during endoscopy, and everybody can see this is the appendiceal orifice. And if in the appendiceal orifice, the iron tablets are looking like this, they are not going to be absorbed anymore. The consequence is, in most patients, nausea, abdominal pain, mostly constipation. However, in IBD, we have a lot of diarrhea. Actually, that's interesting. And this diarrhea, we think, is explained over induction of the so-called Fenton reaction, which produces reactive oxygen species and increases inflammation. So that's why the ferrous iron is not really wanted. Also in the late 90s, a friend of mine, Jonathan Powell, in London, came across a molecule called ferric trimaltol. And he tested this ferric trimaltol in a series of patients who were intolerant to ferrous iron. And what you can see here is actually that those patients who tolerated the ferric iron responded nicely, both in the increase in hemoglobin and in ferritin. This is an old molecule, ferric trimaltol, and they started to do also absorption studies to see how this is absorbed, because it was only thought that ferrous iron can be absorbed and ferric iron cannot be absorbed. So the positive thing about the ferric iron, it would not induce this Fenton reaction. It would not cause reactive oxygen species to occur in the gastrointestinal tract, and it's still absorbed. Obviously, not over the pathways which we know, the regular iron absorption pathways. So when we came across that, we said, why don't we study this ferric maltol in mouse models of IBD? And this ferric maltol, and this is also showing you a picture of 4 different iron products, and they macroscopically look completely different. Ferric maltol is red, and we compared it to iron sulfate, which is the ferrous compound, which is poorly tolerated. And then we said, why don't we add the iron compound, which we thought is 100% safe, which is the ferric EDTA iron, which is used as nutritional supplement and has a so-called GRAS status, which is generally recognized as safe. So the FDA and the European Food and Drug Administration consider this nutritional supplement as 100% safe, and you don't need to label it when you add it to food. And this is an important issue. Memorize that. And the 4th compound came from India, actually. The 4th compound was a curry leaf extract, which was rich in iron. And we also tested this in our mice. So you will be seeing what happened. This is a very busy slide. So just to remind you that we had 2 different mouse models which we used. We started with the AOM DSS mouse model. You give AOM intraperitoneally, and then you give 4 cycles of DSS, and then at the end you kill the mice and investigate. And these were the groups which we studied, the iron EDTA, that is the food iron, the plant iron from India, the ferric maltol, which is at the focus today, the iron sulfate, which we have been using for years. Then we had the iron deficiency control and the regular food control. To make this busy slide easy digestible, everybody can see on this first graph on the top left that there is one line picking up. Whenever you get DSS, the disease activity, and this is disease activity score from mice, goes up. After a week, it goes down again. Then you get the next cycle of DSS. Disease activity goes up, goes down, goes up, goes down, goes up. However, one line is significantly above the others, and this is the red line. And the red line is the iron EDTA, which is considered totally safe and not labeled in food anymore, and available as food supplement, nutritional supplement. It's tasteless, it's almost colorless, and so it's great to add to food. We could not believe this data. We analyzed the data in various forms. This is showing you that the average disease activity was much higher. This is showing you that this is also true for the histologic disease activity, also shown on this section here. This is the regular AOM DSS model, and this is a complete disrupted surface in the EDTA mice. And this is also shown if you calculate the tumor burden. As you know, AOM is inducing tumors. And so this is a chronic inflammatory tumor model. And so we had also an increase in tumor numbers in these mice. So because we were disbelieving this data, we added this IL-10 knockout mice. And these IL-10 knockout mice had to be taken out of the experiment when they were on the iron EDTA after 6 to 10 weeks, because they were so sick that the veterinarian said we need to kill them. So this is again this curve up here, the very sick iron EDTA mice which had to be sacrificed here. The rest of the mice did more or less the same. They were all more or less safe. So this again, IL-10 mice, regular and on EDTA drug. Then we started also to do cell culture models. This is a T48 monolayer, which is stained with a variety of antibodies against tight junctions, adherence junctions, and desmosomes, because EDTA binds calcium. And when it binds calcium, it might disrupt the function of this protective barrier junctions. And what you can see, I hope you can see it, is that, for example, E-cadherin, which is part of the adherence junctions, in the control mice, it's very membranous. Also in the TNF interferon gamma induced mice, it stays membranous. However, when you add EDTA, it becomes more cytoplasmic. So the E-cadherin moves from the cell surface to the cytoplasm and is not present at the adherence junctions anymore. And the same is true for the desmoglein. If you study this in a phytidextran permeability model, you can also see that interferon and TNF is increasing the permeability. The same is true for all the 3 different EDTA molecules that we used: iron EDTA, calcium EDTA, and sodium EDTA. And if you combine interferon and EDTA, you get an additive effect. So what we did is, and this is probably interesting for those of you who do endoscopies, we have this nice device which can do endoscopy with a confocal laser. And this is a confocal laser endomicroscopy picture of a mouse. This is the control mouse. These are nice crypts. And this is the crypts after receiving an enema with EDTA. And what you see is the permeation of fluorescein from the submucosa into the lumen of the crypt. You see these white dots in the middle. So this is an immediate increase in permeability, and this is basically the electron microscopic picture showing that these adherence junctions are opening up, and you increase permeability, and thereby you cause inflammation. So this was not easy to get published, but finally Scientific Reports took the paper. And I warn you of products that include EDTA. Iron EDTA doesn't need to be labeled in the US and in Europe. When we report to the authorities, they said they are too busy, they can't deal with it. So now let's go into the real business of today, into the ferric trimaltol studies, the so-called AEGIS studies. The ferric trimaltol was picked up by a Swiss company and by an Austrian company, and they asked me to run these studies as a phase 3 study. So they were placebo-controlled trials, both in ulcerative colitis and Crohn's disease. It was multi-center, England, Germany, Austria, and Hungary. And it was followed by an open label phase for 52 weeks. Austria couldn't participate because our regulatory office didn't allow us. And then I'll show you a comparative trial between ferric trimaltol as an oral drug and the IV ferric carboxymaltose that is commonly used in IBD. So this is the first AEGIS trial. As I said, it's a double-blind trial. It was 128 patients were randomized into the ferric trimaltol and placebo group one by one. And at the end, anemia status and iron status was analyzed. And after that, patients were going on this open label phase for 52 weeks. They received also ferric maltol twice a day, 30 milligrams. I didn't say that before. And they were followed for 52 weeks. So patients who were on placebo received ferric maltol, and patients who were on ferric maltol were continued on ferric maltol. So this is basically the blinded phase. You see this significant increase in hemoglobin in the ferric maltol group, and this no change in the control placebo group. Importantly, the inclusion criteria for this study were that the anemia was not supposed to be too significant. The anemia should be above 9.5 because we didn't want to randomize against placebo in heavily anemic patients. This is why the average hemoglobin was 11 here. But the increase was really nicely and significant up to over 13 within 12 weeks. If you look into the response rates, response above 1 gram hemoglobin was almost 80% of the patients treated with ferric trimaltol versus placebo was 11. If you make it more stringent and say above 2 grams, it's only in the ferric trimaltol group. None of the placebo patients did go up more than 2. Or if you look into normalization of hemoglobin, this was also 2/3 of patients on ferric maltol normalized within 12 weeks. If we look into the data from the follow-up group, and these were published separately, here is the randomized group, which I just presented to you. This is the same thing, basically on placebo, almost no change. On ferric trimaltol, when those placebo patients came on ferric trimaltol, they were catching up and similarly normalizing like those who were on ferric trimaltol in the randomized trial. If you look into the number again of normalized hemoglobins after a year and 12 months, it's between 86 and 92% of the patients. So this is, I think, a real problem solver. And this is not only true for the hemoglobin, also the ferritin, the iron storage protein, goes up, which we barely see on ferrous iron compounds. Most interestingly is the side effects table, and I really want you to focus on placebo and ferric maltol in the blinded group. So this is gray and purple. So the gray bar is placebo, the purple bar is blinded ferric maltol, and it's a little bit up and down. Nasopharyngitis was a little bit more in the placebo. Abdominal pain was a little bit more in diarrhea in the ferric maltol. Ulcerative colitis worsening was a little bit more in the placebo. Flatulence was a little bit more in the ferric maltol. And none in the placebo. Constipation was a little bit more in the ferric maltol. Crohn's disease worsening was a little bit more in the placebo. So actually, there was no real sign of a side effect on these ferric maltol treatments. In the past, we compared ferrous iron with IV iron. So this was basically our past, where we developed various IV irons. And this is a study comparing ferrous sulfate with iron sucrose. This study compared ferrous sulfate with ferric carboxymaltose. Excuse me. And it's interesting to see what the side effect rates are. 24% for ferrous sulfate, and here 8% of ferrous sulfate. When we overlay these studies with our ferric maltol trial, which is here the blue one, you see that the response rate is actually very, very nice. So it had the highest hemoglobin at the end, Having said that, it also started at the highest point in the beginning. So it was logic that there was a direct comparative trial, which was done in Germany by my German colleagues. They compared the ferric maltol with ferric IV, ferric carboxymaltose. And if you look here, the ferric maltol is the gray curve, and the ferric carboxymaltose is the bluish curve. The ferric maltol, it was a non-inferiority trial, and it was considered inferior until week 12. So these differences here at week 4 and week 12 were significant. However, after that, it was completely non-inferior. So having said that, it takes a little bit longer that the drug can solve the problem of iron deficiency anemia and IBD, but at the end it does, latest after 24 weeks. Again, looking into side effects in this trial, this on the left side is the ferric maltol group. Here is the ferric carboxymaltose group. There was an unrelated death in the ferric maltol. And if you look into the treatment-related adverse events, there were 20% here, there were 6% here, leading to discontinuation, 10% here, 3% here. And again, if you look into the specifics of these side effects, abdominal pain seems to be an issue in 9% of the patients, nausea in 5%, upper abdominal pain in 6%. But if you look into colitis flare, Crohn's disease flare, diarrhea, that's very well comparable in between the groups. So we consider this ferric maltol a real improvement over the ferrous compounds in patients with IBD. And let me summarize this. We think it's an effective treatment. It's an effective oral treatment for anemia and IBD. In mild IBD, it's very comparable to IV iron. It has a very favorable safety profile. And from our mouse models, we can say it's not the iron, it's not the ferrous, it's not the ferric iron that is really bad for the mice. It's the EDTA compound, which is part of food industry, and unfortunately very difficult to track because it's mostly not labeled. So this is a final picture of my group. You see, I'm still young on this slide. This is probably 10 years ago. So, but I did have an Indian coworker which left back and is now in Varanasi. She was our senior postdoc overlooking all these trials. I did have a Philippine postdoc also overlooking. I showed you data from Raiko Estatiev. And Stephanie, no, Stephanie's not on the slide. I'm sorry. She was not at that meeting. But anyway, so this is the group back then. Maybe to warm up for the discussion, I prepared 2 cases out of my last week. And these 2 cases should show you where I think is really the spot for this compound. So at least in Austria it is. So this is a female patient, 36 years old. She's married, has 2 children, and she's also vegan. She has extensive UC. Actually, I do have a lot of vegan UC patients. I think they get vegan because they hear that that meat is bad for UC. So anyway, she has an extensive UC since 15 years. And always some mild anemia, was treated with azathioprine, 5-ASA, and we started infliximab in 2015. And when we do IV infusions with infliximab in these anemic patients, it's always very simple to add an IV infusion afterwards. And typically we give them iron sucrose at a moderate dose. In her case, it was obviously 4 to 5 infusions per year. Then she got pregnant. She had 2 pregnancies, and she stopped with the infliximab at that time, and she stopped also with the azathioprine. She just continued on the 5-ASA, and she got sicker. And we tried to restart the infliximab in 2022. She had antibodies, didn't respond well, so we switched her to Entyvio, vedolizumab, induced her IV, gave her iron sucrose at that time. And this is showing you basically the curve over the years. Here, infliximab and iron sucrose. Here was the pregnancy somewhere. Somewhere here was the pregnancies. And then she was switched here to vedolizumab. And when she moved from IV vedo to subcutaneous vedolizumab, she went on ferric maltol twice a day, on and off. And if you look into her hemoglobin, this is really nice for a young woman. It was mainly above 12 and almost up to 14 in the recent tests. So this is basically a case where we don't use IV drugs anymore, and then we switch to subcutaneous. We don't want to give the iron IV extra, so we switch to ferric maltol. This is an interesting case. Maybe this is interesting also to share here. This is a guy, and the guy, of course, is bleeding only from the gut, and he had Crohn's disease, and this is, of course, the Vienna classification, not the Montreal classification. L4 means upper small intestine. He had his terminal ileum affected, and then he had a skip lesion, which was 50 centimeters proximal to the terminal ileum. And then he was resected in 2012, and also 20 centimeters of the proximal terminal ileum was resected. So he had a ileal anastomosis and an ileocolonic anastomosis. He was put on adalimumab and then infliximab. And then he developed a stricture at the proximal anastomosis, and the surgeon did a strictureplasty. After that strictureplasty, things went down in terms of bleeding. He started to bleed terribly. He used 3 to 5 grams of ferric carboxymaltose a year. This is compared in blood. You have to say 1 gram of ferric maltose is about 5 blood transfusions. So you can say this is 25 blood transfusions per year. So, and the hemoglobin was between 6 and 8 in this period of time. So very, very bad hemoglobin. In 2024, I put him on golimumab in combination with ustekinumab with Stelara. And because he was not on infliximab anymore, he received also ferric maltol. And you can already see here what happened to the hemoglobin. His last hemoglobin here is almost 16, and this is showing you that I'm not cheating. This is up here 15.8, that this is most recent from July 2025. So that was a real winner. Both the combination, I think, of the golimumab, ustekinumab, and the ferric maltol, but also what I do, and we can discuss this whether you do it as well. I go to the bleeding site, and specifically when it's at strictureplasty, at anastomosis, it's commonly ischemic bleeding. And you see here the strictureplasty area, and you see these erosions which are lightly bleeding spontaneously during the endoscopy. And I use a lot of argon plasma coagulation in these patients repeatedly, sometimes 3 times. I think I did it in 2 times in this patient to improve wound healing and reduce the bleeding. So I think having said this, I'm at the end of my presentation, and I'm happy to take your questions. Thank you for listening.
Thank you very much, Professor Christoph, for that wonderful exposition of the topic. And your message was very clear and loud that, oral ferric maltol is not inferior to the IV drugs, in especially the mild IBD. And you also stressed the carcinogenesis and inflammation is due to iron EDTA rather than the ferric maltol. I think I request all the moderators from various centers, please send your questions and we'll ask Professor Christoph, you can clarify your doubts. Now I'll ask from simple question. What is the dose you advise in a mild anemia or a moderate anemia in oral ferric maltol?
So in the trials, we always used twice a day, 30 milligrams. The drug comes in 30 milligram
Professor
tablet.
Christoph Gash, sir, it was a wonderful talk that you have given us. We could see the extent of research that you have carried for over a period of several years. I could see in one study you've been given for 52 weeks you were giving iron. I don't know which patients have continued for so long. And I have just one doubt, sir. Did you do studies in patients other than IBD with this ferric maltol group?
No,
It's only the IBD patients?
it was designed for IBD patients in the first run. But of course, there were a lot of studies others did in nephrology, in women, I'm not sure about pregnant women. No, I don't think they did pregnant women, but women and in dialysis and pre-dialysis patients.
In fact, Professor Christoph, her question is, in a case of iron deficiency anemia where there is no IBD or inflammatory bowel disease, have you got any experience of using ferric maltol as a routine therapy for iron deficiency?
My wife is using it a lot. My wife is running the iron clinic for women at Loa for Life, and she's basically using a lot of ferric trimaltol in women. It is always a matter of the price. In Austria, it was previously very expensive. I don't know what the Indian price will be. So this is something you have to keep in mind, and reimbursement. But in terms of tolerability and effectiveness, I think it's the best oral drug that we have.
Yeah,
So,
cost effectiveness is one point which you have stressed, cost effectiveness. In a routine iron deficiency anemia, compared to IV preparation, this oral ferric maltol also is equally effective. So cost effectiveness, if you give for about, as you said, 24 weeks, I think it's a good buy about the ferric maltol. But generally, you don't use ferric maltol in a routine iron deficiency other than IBD because you had more experience and more you have done yourself only in IBD. So we can use ferric maltol because you have given the safety profile, the side effects compared to ferrous sulfate and ferrous fumarate and ferrous gluconate. The side effects of ferric maltol is much less. So we can give only thing about the cost effectiveness and the individual, type of anemia. We have to choose the drug. Over to you. Yes, please. You have one more question, madam.
huh. So I understand that since its sister molecule ferric carboxy maltol is we are giving IV, so oral preparation is not having any side effects, and we can give it in people without IBD also. That is what we have understood. Maybe we need some more trials in patients other than IBD and who cannot tolerate other irons. Over
Yeah,
to
in fact, Professor himself said his wife is using a lot of those things in our clinic, iron clinic. So, but regarding the research and regarding his aspects, he had been using this on IBD. Any other question from any other center, please?
Good
You can
evening.
put-
I'm
yeah,
audible.
yeah, please go ahead.
Good evening, Murungnathan sir. How are you?
Yes, fine, thank you. Yes,
First of all, let me congratulate. I'm Dr. Shankar from Nagpur. I would like
yes.
to congratulate Professor Christoph for his excellent talk, which has given very in a simple way. My questions are because iron, suppose given daily, it will prevent the absorption of the second dose. So best treatment is to give alternate doses, alternate day iron, because suppose we give daily, the hepcidin level will increase. And that's why we have a habit of giving alternate day. So I would like to have your opinion on this.
Yeah, thank you for that. Thank you for that remark. The studies were designed twice daily, but in clinical practice, I fully agree. I would not give it twice daily. Whether you give it daily or every second days should be fine.
Yeah, now Shankar, they are using alternate day therapy also. I mean, people try that also, and that seems to be very effective. Yeah.
And
Any other questions, Shankar?
my second question is, iron deficiency anemia. It is a nature's phenomenon because in malaria area, endemic areas, the patients who are having anemia, they don't develop malaria or E. coli because there is no iron to use by the bacteria. And suppose we give more iron to such patients, then or even in a patient of sickle cell anemias and all that. So most of the time the infection is again. So what is your take on this?
So my experience with malaria is zero. We do not have malaria in Austria, and I have to pass this question to doctors who are dealing with malaria in their areas. But we have a general rule that septic patients, and malaria is obviously a septic disease, should not be given iron at all.
Yeah, depends on the severity of the problem. So individually it varies. We cannot give open statement. Don't give iron in malaria. That depends on the individual situation. You have to do evaluation. You have to do transferrin. You have to do the saturated ferritin. All those things. And in fact, ferritin and CRP is one thing which you do so that you rule out inflammation. And if there is an inflammation, that things will change, and depends on the individual. You have to balance the whole thing. We cannot say straight away iron cannot be given in a malaria case. Of course your logic is correct, but you'll have to individually vary. Any other question from any other center? Gawati, are you there? Hyderabad? Yes, please introduce yourself and ask the question.
Dr. Dipjoti from Guwahati. Sir, I want to ask the question that the studies have been mostly done on inflammatory bowel disease. So, can we extrapolate this to other clinical conditions? And my second question is whether this alternate day therapy is preferable in all the conditions. Yes.
How to be clear? We started using ferric maltol in IBD because we knew that the oral tolerability of oral iron is worst in IBD patients compared to other conditions, such as, for example, women, which are otherwise healthy besides their monthly menstrual blood loss. So that was the reason to study ferric maltol in IBD population. And the second thing is we wanted to see how effective it is. So we started with a quite moderate dose, but twice daily. Moderate meaning 30 milligrams and twice daily. If you compare to other iron compounds, which we have on the market, they are 100 milligrams, and some are used iron sulfate 300 milligrams a day. So this was basically our approach in the study design, to have a significant reduced dose compared to iron sulfate, but still to have a twice daily dose. There is no trials, as far as I know, that tested ferric trimaltol as an alternate day therapy. And I have to say that the absorption process of ferric trimaltol is not undergoing the same absorption process that ferrous iron is doing. We think that ferric maltol is passing the cell membrane in an indirect way and going into the enterocyte without any transport protein. And so the reason is that the intake into the enterocyte should be good. The question is whether the ferroportin part of the enterocyte that brings the iron into the circulation is also good. So we are currently proposing an alternate day approach in patients that are not significantly anemic. They are just basically moderately anemic and need a support. And then we're checking this after 4 or 8 weeks, depending on when we see the patient again. And we would adjust the treatment in the frequency and the dose.
Professor Christoph, practically, how long we'll have to wait before we take food? I mean, empty stomach, how long after the tablet we take the food?
I think with ferric maltol, it's totally unproblematic to take it with food, before food, or after food. The absorption process should not be inhibited by food.
Okay.
Excuse me. Hello. I am Bhuvaneshwar, Dr. Bharadwaj Misra speaking.
Yeah.
In how many days in a pregnant woman, if you give this iron therapy, it will have how much of a rise in hemoglobin?
Pregnant women are various. There's pregnant woman with a hemoglobin of 7, and there's pregnant woman with hemoglobin of 11.5. So, and according to the hemoglobin, the rise will be always much better in those who start with a lower hemoglobin. So you can expect a rise of 2 within 8 weeks if you have a low hemoglobin, such as 7, 8, 9. If you have a hemoglobin above 10, the rise will be maybe 1.5 to 2 grams in 12 to 16 weeks.
In a ferric maltol, is there any drug interaction? You have to avoid some drugs when you give ferric maltol, in your experience?
I don't recall. No, I don't recall that we were.
What about PPI? What about PPI? Can we take PPI, protein pump inhibitors, along with the ferric maltol?
That's a good point. I think the answer is yes, because it does not need to be reduced to ferrous iron to get absorbed. It's the ferric molecule that transmigrates through the cell membrane, and it does it because it's in a molecule within 3 maltol molecules.
In a ferric maltol, the unabsorbed iron, will it disturb the dysbiosis? Can it cause microbiota disruption or any such incident?
There is no studies on that. There's studies on ferrous sulfate and IBD, but on ferric maltol, I'm not aware of any dysbiosis studies.
Any other question from any other center, please?
But you have to keep in mind, every germ needs iron, and iron is the best growth factor for all the germs. So it would be surprising, and it's a dose-dependent effect. So if you give 300 milligrams, you will have a lot of effect on the dysbiosis. If you give 30 or 60 milligrams a day, it's much less.
What about any chronic conditions like heart failure, hypertension, ferric maltol? Because iron deficiency always accompanied by hypertension, diabetes, and heart failure, obesity. So, is there any particular thing when we take precaution?
I don't see any problem at all to give this to patients with heart failure, chronic kidney disease, or any other condition.
Any question from the other side, Hyderabad?
Hi, I'm Jin Macha. I'm a consultant physician. I'm really surprised about the AGIS study that with the such kind of IBD and damage to the mucosal absorptive surface, this ferric maltol is able to get into the blood. So what other mechanisms play around in this absorption process?
I was not hearing the first part of your question. It was a little bit not loud enough, but I think you were asking what is the absorption process of ferric maltol?
Correct.
Yeah. So we believe that it transmigrates through the membrane without using a certain receptor. And within the enterocyte, it's released. And then over ferroportin, it passes into the circulation.
Bhuvaneshwar, you were asking some questions. Please, Bhuvaneshwar, over to you.
Yes. a lady having 7 gram percent hemoglobin, but how many weeks it will take using this ferric maltol? 30 milligrams or 60 milligrams using, how many weeks it will take achieve 11.5 grams?
So we had a normalization in 50% of the patients in IBD within 12 weeks.
Normal, not IBD.
Normal, yes.
Professor Christoph, how long you are using this ferric maltol? Maybe 2 years since?
No, we use it since 2015.
Oh, so using for quite some time. And it is marketed in Europe and USA, and then it is, the cost effectiveness is good compared to the parental iron, isn't it?
Excellent, yes.
Okay. And any particular side effect which you come across in your practice so far in ferric maltol?
No.
Okay, fine. Anybody else? Nagpur? Yes.
Yeah. I'm Dr. Shankar. Good evening, sir. Muruganathan, sir. Thank you for allowing me to ask the question. There are so many patients of autoimmune disorders, and they are having anemia along with that. So, what is the role of this, your molecule, in autoimmune disorders?
You mean in autoimmune disease?
Yeah, autoimmune diseases, they are having anemia.
It's basically anemia of inflammation, right? That's what you...
So it is an inflammatory process, and there are so many free radicals.
Yeah.
And because of the free radicals, there are so many cytokines and the interleukin-6 and all that. So
yes.
suppose you give most of the patient of SLE or some, they are anemic, they are diagnosed as, or so many diseases having anemia. So we change the scenario, this molecule, maltol, because it is a liposomal.
Liposomal.
Yes. And so your experience, have you tried this in autoimmune disorders?
I would not use iron for treatment of anemia of inflammation. You know, anemia of inflammation is treated either with anti-inflammatory drugs or with EPO. So that is our approach. We don't use iron for anemia of inflammation.
Okay. Thank you. Thank you so much.
Okay. Any other last question?
I am Dr. B.N. Patnaik from Bhubaneswar.
Yes.
IV ferric maltose can replace blood transfusion in a patient having hemoglobin 4 to 5 gram percent. It requires operation urgently.
We have excluded patients in our trials with significant anemia. So patients all had hemoglobins above 9.5. So having said that, I would not start in a patient with a hemoglobin lower than 8 with an oral iron drug. I would rather propose using IV iron in significant anemia, because you saw that the IV iron is faster in the increase in the first 12 weeks. I think the drug is very good for long-term use, for switching after the significant anemia into the maintenance therapy.
And Professor, you are saying people take this ferric maltol for more than 40 weeks. I saw one of the studies, 64 weeks they take. So the adherence is good when there is no side effect, isn't it? Your experience?
That is correct.
Yeah. And it slowly and steadily increases the hemoglobin.
Yes.
Yeah. When do you escalate the dose? Suppose if somebody doesn't improve, will you escalate the dose of whatever you said, 30 milligram twice a daily?
Yeah, I think that is the highest dose we would use. Twice a day, 30 milligrams. But, you know, compared to other drugs, to the other oral drugs, to ferrous sulfate, this is a very low dose. All the studies with ferrous sulfate were done typically between 200 and 600 milligrams a day.
If there is no improvement after 12 weeks of ferric maltol 30 milligram twice daily, will you increase the dose?
No, I would switch the drug.
Okay, fine. I think any moderator final comments from anybody? I think
by Professor. So big round of applause for him. He has done a lot of research on this molecule.
Yes.
And today today evening he has enlightened us on this very important topic, which is very common. And it is the suspicion by the physician that any patients having this weakness, fatigue, lethargy, or so many diseases can be suspect that he is having iron deficiency anemia, and this molecule should be used properly. Thank you so much. Excellent.
Yeah, one more drive home message for all of you. Just like routine blood sugar, routine blood pressure checkup, you should also do routine blood tests to rule out anemia, to rule out iron deficiency, because many of us do not do the routine blood test. And if there is a CRP and ferritin is more, then it means it's a inflammatory disease. And also there will be no anemia, but still iron deficiency will be there. So you have to have proper evaluation. You must find the root cause. And if there is a coexisting inflammatory condition, you must also comorbidities, you have to simultaneously treat. The awareness is important. All the association people should educate the public, especially pregnant ladies, because ladies have more problem. And then you first find out the cause of bleeding, cause of anemia, and then treat and approach properly. So if you do the proper algorithm and strategic approach, this can be tackled. I think I take the opportunity to thank Professor Christoph Gaske for all of you that you have given very, very good information. His information was loud and clear. And I thank the organizers for giving this opportunity. I thank all the delegates. I can see so many of my good friends are there attending at this point of time. Thank you very much. Please convey this to your friends and start practicing in the way it should be. Thank you so much. Over to you, the technical team.
Thank you.
Ramnath, thank you.
Yes, sir. Yes, sir. Yes, sir.